As orthopedic surgeons, we're not trained to ask the relevant questions. I mean, asking someone whether they have incontinence with sneezing or coughing.
Yeah.
So it's nothing to do with orthopedics. So you don't want to go there. Is intercourse painful? Do you have any problems with your bowels?
Yeah.
These are not questions that are going to be regularly asked. And a patient, even though they have those problems, have you got prolapse, etc., they're not going to volunteer because they also think that's nothing to do with my joints.
Yeah.
But unless we start asking the questions, we won't be able to give the appropriate treatment to these patients.
Welcome to the 51%, the podcast where we cut through the noise and get back to basics when it comes to women's health. Through expert insights and powerful personal stories, we help you tune in to what really matters: your body, your well-being, your life. No one-size-fits-all advice, just real conversations to help you understand your health on your own terms. But before we dive in, I have a quick favor to ask. Please hit subscribe and join the 51% community on our website. It's free and it helps us grow, reach more women, and create events that really speak to the health and wealth challenges we all face. And finally, just so you know, everything shared on this podcast is for information only. It's not medical or financial advice. And always speak to a qualified expert for support. Samantha, welcome to the podcast. It is great to have you on, and I cannot wait to have this conversation. Could you please introduce yourself and talk a bit about what you do?
Treya, thank you so much for inviting me onto your podcast. My name is Samantha Tross. I'm a consultant hip and knee surgeon practicing in London. I work both in the NHS and in the private sector. And I am particularly interested in the impact of hormones on musculoskeletal problems. And so I'm delighted to talk to you about it today.
That's great. Thank you so much. So is there a difference with musculoskeletal conditions with men and women? And could you highlight that? And how does hormones have an impact on that?
Women are more prone to musculoskeletal conditions for a number of reasons. One, because of our physical build-up, the way that we have a wider pelvis in relation to our knees. And so that angle between the pelvis and knees means that the quadriceps muscle from the origin around the pelvis to the knee causes significant vector forces on the knee joint, leading to problems such as anterior knee pain because of the stress on the kneecap, putting you at risk of having ruptures of the anterior cruciate ligament. Also because of the way, the mechanics of women, the way that we walk and we land, we are more prone to conditions such as ankle sprains. Because of the hormonal impact, then you have things such as osteoporosis later on in life with menopause. During certain times in the menstrual cycle, you're more at risk of having ACL injuries. So I think for a number of reasons, it's the physical makeup, our normal biomechanics, and then the hormonal impact. So it's multifactorial.
In terms of hormones then, because obviously girls go through puberty and then they hit menopause, go through perimenopausal symptoms. So there's different phases of women's life where their hormones are changing. Is there a difference between girls when they're younger and then a woman when she's going through perimenopause in terms of musculoskeletal conditions or issues that they might get? A lot of women get aches and pains, and girls do as well. But is there a key difference between that kind of age group?
Yeah, I mean, there are key hormones that are relevant to musculoskeletal conditions: estrogen, progesterone, and relaxin. And these hormones fluctuate throughout the menstrual cycle. And certainly in menopause, the levels drop. And it's to do with the function of those particular hormones. So for instance, estrogen, well, they all have impact on the musculoskeletal system via the impact on collagen metabolism. So estrogen stimulates collagen generation, and a lack of estrogen, which happens in menopause, means that the collagen synthesis doesn't take place. And then you have cells that break down bone, such as osteoclasts. When you drop your estrogen, there's more osteoclastic activity, and that's why you tend to get osteoporosis. Collagen's important. It gives elasticity to your skin, to your tendons and the muscles. And collagen is found in bone as well as in ligaments. So when you have a drop in the hormone levels, you lose the flexibility, and also your bone turnover is greater, so you get osteoporosis, as I mentioned. Now, during the menstrual cycle, fluctuations also occur, such that high levels of estrogen and relaxin can make tendons more lax. So it's good, to have levels, or if it's too high, then of course you get a laxity. And laxity is good because you want to be nice and flexible, but it just means that the joints can move a bit further than normal, and then it puts you at risk of injury. So we have to try and counter that by strengthening muscle. And often the muscle strength and the bulk of muscle is not as great in women as in men. So that's where we have some issues.
I guess with hormones then, you talked about when you're going through your menstrual cycle, every woman should be looking at their menstrual cycle and then going to the gym and doing certain exercises according to that. Is that true? Because, you know, going through a menstrual cycle, if you're having your period, at some points you can feel more tired or have more aches and pains. So at that point, should you be reconsidering what you're doing? Could it be more harmful when it comes to exercise?
Definitely those variations occur, and at certain levels you're more prone to injury. The difficulty is that the menstrual cycle in women varies in terms of the period during which they are menstruating. The overall cycle is the same length, but there are times when you may not want to go and exercise, but it's important that we do exercise. You may have to change the pattern of exercise, but I think it's so important for women to build that strength and build it early, because that can lead you in good stead later on. So yes, there needs to be greater awareness that certainly around the time of ovulation, that's when you're more at risk of injuries. In the early stage as well, when you are menstruating and just before you ovulate, then you also have low progesterone levels, and the progesterone can impact it is anti-inflammatory. So when it's low, then there's more inflammation of joints as well. Right. And also your pain perception also goes up. Right. So it's all linked. I think the message is it's important to exercise. That has to come through. Yeah. But there are times when you need to be aware, and you've got to make sure that when you do your exercises that you're doing them adequately. So you're taught how to use the equipment well, and that you do it gradually and not do any sudden increase in weight, lifting, etc.
So when it comes to injuries, what kind of injuries are women more prone to when exercising? We're talking about women that are going through that perimenopausal phase.
Yeah. So when you're around perimenopause, everything is becoming a little more tight. Your ligaments tighter, you haven't got that flexibility. So you wanted to avoid activities which involve sort of extreme movements and doing that too suddenly. It's so important that you warm up, you loosen the joints, and you gradually build up your strength. That's important. And then you make sure that when you exercise the muscle groups, that they're balanced.
I know osteoporosis is also quite a big issue for women. What would be the key things women could do to prevent that, or at least make sure that their risk is reduced quite a lot? Well,
I think the important thing is that you should build up your muscle strength whilst you can. So when you're younger, you can keep a store for later. So it's important that you do regular exercise, that you keep your weight under control so you don't have extra stress on the joints. But look at your diet, so making sure that you have adequate calcium. And I think in this country where we don't get that much sunlight, we need to be monitoring our vitamin D levels and taking supplements as required. So, loading the bone is what strengthens it. Obviously, as I said, as we get older, when the hormones reduce, you're more at risk of injury. So when you're young is a time when you can really have the most impact. And so that's what you need to do. But maintaining exercise even after menopause is important. So it's about diet, it's about exercise and monitoring your vitamin D levels.
There's this huge thing with strength training now and making sure you build muscle and also have some impact on your bone. Is there a risk of doing too much? And can that impact your, aches and pains and perhaps even lead on to you having surgeries?
Yeah, there's always a risk of doing too much. I mean, that can happen to men as well as women. Yeah. We are more prone, as I said, because of our anatomy, the way that women naturally, the biomechanics, when you take a step and you're running and you're jumping and the way that you land, and we do that in a way that's different to men. So there are lots of things we can talk about. I mean, the width of the pelvis, the fact that your hips tend to be internally rotated, your femoral bone is adducted. That means that your knees, the alignment between the knee and the lower leg means it's more of a valgus angle. Valgus means that the ankles are apart where the knees are together. So that puts you more prone to having these injuries. But the things that we are more prone to have are things like inflamed joints, particularly around the pelvis, because women also goes through childbirth most often, and we tend to have weak pelvic floors.
Yeah.
And the muscles around the pelvic girdle tend to compensate for each other. So when that's weak and your core muscle is weak, some women may have had cesarean sections as well that may have weakened it further. Then the muscles around the buttock and pelvis, they try to compensate. So you get inflammation of those tendons. Then we talk about problems with the knee joints, ankle sprains, etc. And the risk of doing too much exercise. That's why I say you've got to know the equipment, you've got to use it well, you've got to wear the right footwear. All of these things can impact. And when you do the exercise, you've got to do it in a gradual way and build up the muscle groups. And then as I talked about, making sure that the muscle groups are equally balanced on either side. And we tend to have in women weak gluteal muscles, and our hamstrings and quads are not as strong as the men. So these are things that we really need to work on. And then the flexibility is very important. So making sure that stretching and that cooling down is also part of that. And then I think consideration needs to be given to things like hormone replacement therapy. Now, of course, people have concerns about that. I would advise you to go and get advice. And particularly if there's a family history of any cancers or anything like that, then obviously that needs to be considered. But there's no doubt that replacement therapy can also address some of these complaints.
But I guess they can't fully compensate for...
No, definitely not. So you've got to do the exercise. Also, as I said, strength, flexibility, weight, making sure that you don't carry any excess load, you don't carry excess body weight, and then balance out with diet, plus or minus hormone therapy.
Do you think it's important to then, as an example, if someone wanted to start running, but you've never ran before and you've not really done much weight training, so your muscles aren't perhaps as strong as they should be, but you just go straight into running, could there be a problem with your muscles not being able to support because they're not strong enough when you're going on that run or doing cardio type exercise with impact,
Sure, yes. If you ask a muscle to do something beyond its capability, it's going to get inflamed. So that's where you're going to get tendinopathies. That's just an inflamed tendon. You might get a muscle tear. But then also you're stressing the bone, which hasn't been stressed before, and there's a risk of getting a stress fracture.
Right.
So apart from the muscles and ligaments, there's also a risk of injury to the bone. That's why it's important that it's done gradually.
Yeah.
You've got the right footwear, you use the equipment well, and that you take time and really strengthen the muscle and all the muscle groups that support that particular joint.
I guess from my point of view, it sounds like it's a good idea to do some strength training,
yes,
weights of some sort.
Definitely.
Before you start thinking, right, I'm just going to go on this run.
Exactly. And don't get up cold from the sofa and go and run. You've got to warm up. You've got to stretch. You've got to loosen the joints.
Yeah.
And when you're running, you start off, of course, you got the adequate footwear and so on. You go on the flat and you pace yourself. You gradually build up the distance and of course the sort of terrain, the inclines and so on, so to protect yourself from injury.
What kind of injuries do you see more prevalent in women?
I'm a hip and knee surgeon.
Yeah.
So I tend to see a lot of gluteal tendinopathy or bursitis. So people talk about bursitis. I mean, it's very difficult to differentiate between a tendinopathy and a bursitis or even a tear. What are they? The tendon is the part of the muscle that attaches to the bone. That's called a tendon. And the gluteal muscle, which is in the buttock, which helps support the pelvis, they are three muscles. There's the outer one called the gluteus maximus, then you've got the medius and then the minimus. And each of them have a tendon. And between each tendon is a thin fluid-filled sac called a bursa. Stops the tendons sort of shearing across each other. And that bursa can become inflamed, but it's difficult to tell whether it's the bursa is causing the pain or the tendon, etc. We now refer to the whole thing as greater trochanteric pain syndrome. The greater trochanter is a location on the bone that they insert. And so we just call it syndrome, because pain from any of those areas. So I see that very commonly.
Yeah.
And luckily, most of these conditions can be addressed. They don't require surgical treatment. The mainstay of treatment is physiotherapy. And really paying attention to not strengthening just only the gluteal muscles, but the other muscles that help support that. So your core muscles, your pelvic floor muscles. And I think the pelvic floor is something that's often overlooked. We can do just core, that won't be enough. So working on the pelvic floor and, improving posture and flexibility. Yeah. So gluteal trochanteric pain syndrome is greater trochanteric pain syndrome I see a lot of. I see an anterior knee pain, and I'm starting to see increasing numbers of anterior cruciate ligament injuries as well.
With the knee pain, I often wonder, so as an example, my mum has had a partial knee replacement.
Yeah.
And I see and hear of a lot of people getting knee replacement surgery now. And my question is, sometimes I think, is there a way to avoid this kind of knee surgery? Or to at least be on the path to make sure that you do not have surgery, because I'm seeing a lot more.
You see a lot more people.
Yeah.
I mean, look, there's no doubt that genetics plays a part. And so some people have the genes that unfortunately predispose them to arthritis early, and they can't help that. But things like weight reduction, the more weight you carry, the more stress to your bone, to your joints. So looking at your weight, having a healthy lifestyle, having a balanced diet. So what you put into your body is also important. But that's sort of keeping the joints mobile and flexible and doing regular exercise, having the muscles act as as shock absorbers. So if you have your muscles well toned that support the joint, then that prevents more load going to the joint. Paying attention to our footwear. There's so many things that we can do to delay the onset or prevent.
So I guess if you're genetically predisposed, then you're going to have that anyway.
Yes.
There's no way of just preventing it. You're more likely to get
it.
But how do you know if you're genetically predisposed anyway?
Well, there'll be lots of members in the family who have had it at a very young age. And maybe your granny or someone has it. I mean, that's just part of aging. I mean, when we talk of arthritis, there are a number of different causes of arthritis. There's primary osteoarthritis, which is the arthritis of aging, which some people can age earlier than others. And then there are other conditions that cause secondary arthritis. Secondary means caused by another problem, such as rheumatoid disease, such as previous trauma, such as a previous infection, underlying metabolic bone disease. So there are other things that can also cause, which sometimes again, maybe genetics.
So I guess it sounds like if you do have a knee problem or perhaps need surgery, it could be because of arthritis. Arthritis has a direct link to these issues?
Yes, it could be. So my thing is that if you have experiencing knee pain and you tried conservative measures such as modifying activity, painkillers, weight reduction, and physiotherapy, and symptoms persist, then you should seek some advice from a physician, from a surgeon.
So let's kind of touch upon HRT now, because I think there's a lot of debate on that, and also you get some group of women that really want to take it and do take it, and then there are some group of women that don't want to take it. Now, I know it's not a complete solution. If you take HRT, then you're going to be fully functional like you were maybe in your 20s or 30s. But if you don't go down the HRT route, as an example, are you increasing your risk of getting certain issues with your joints and bones? Or if you choose not to, are there other ways you can kind of mitigate it?
Yeah, I mean, inevitably we're all going to age.
Yeah.
And the problem is that when you do go through menopause, your hormone levels drop. So that's inevitable. And we know that estrogen and progesterone affect the metabolism of collagen. They also impact the cells that cause bone generation, and then they have impact on the flexibility of the joints and so on. So that's going to happen. When you have reduced progesterone, sometimes you're gonna feel inflammation in the joints. You can have two people with the same amount of hormone levels and have different symptoms. We know that you can counter that by doing exercise to try and keep the joints flexible as possible. Stretching is important, and also trying to strengthen the muscles to support the joints, and also stimulate the bone turnover by gentle stressing of the bone is good. So there are things you can do to minimize your symptoms. I don't think necessarily going to be completely asymptomatic, but people have different symptoms. Some people actually sail through, they're not aware of any problems, and then others are very symptomatic. So I don't think everyone needs HRT from an orthopedic point of view. Now, hormones have other benefits, like they predict the neurological function and cardiovascular function, but I'm not an expert to talk about that. But I'm talking just from the joint point of view. From the joints point of view, certainly by doing exercise and so on, you can control your symptoms. Taking regular analgesia, etc., keeping your weights under control, those things can help.
Yeah. So I guess HRT, if you choose not to take it, there are other ways to help and mitigate.
And then they have, biological formulas and so on. I mean, I'm not an expert on HRT, but there are other type of hormone replacement therapy that's not animal products. It could be plant-based and so on.
Oh, okay. I wasn't aware of that. You should definitely speak to your GP about if you want to go down that route. So I guess with HRT, it's not a complete solution.
No, it's not a complete
to
solution.
prevent.
And the thing is, once your joints have become stiff, you don't take our HRT and it's suddenly flexible.
Yeah.
You know what I mean? That's why it's important to maintain this all the way through. But there's no doubt, and this is speaking from personal experience, and I take HRT as a personal choice. With that, a lot of my joint pains did improve.
Yeah.
It didn't make me any more flexible. I'm still I'm having to do the work to do that. But, I was an athlete, and so, my bone strength is good. So I banked that luckily early. Because when you go through menopause, you lose 30% of your collagen within 5 years. I mean, that's why you get very stiff. So it happens quite quickly. Try and keep going and keep gently stretching and so on. That's the key. Exactly.
What would you say would be your kind of advice to women when it comes to their bone and joint health? Because there's a lot of stuff out there on social media, just in the media generally, about do this and do that, and it's quite overwhelming. And then everyone's trying to do so many different things. There's too much, and then they try and take on too much and then fail at almost all of it. What would be your advice to women? What should they be focusing on and just for their bone and joint health?
Yeah, I think the important thing is diet, adequate rest and hydration. That's very important. You can't go and do exercise on muscles that there's no energy and they're dry. So, that's key. And then you want to keep your weight controlled. That's key. And then the important thing is the strength. Keep your strength up. Keep your flexibility. Those are the key things. It's really be safe in terms of when you're doing your training, making sure you get adequate advice in the equipment that you use. Build up gently. Importance of warming up, cooling down, So you warm up the muscle before you get into activity, and afterwards the stretching. That stretching is really key.
Like I said, a lot of women are confused by what they should and
this
shouldn't
collagen,
do.
that collagen. I mean, look, these things may help, but I think the basics is what you have to get done. And the basics is pay attention to your diet, get enough rest. So don't go try to use equipment and stuff on retired muscles. So make sure you're well rested, and then gradually build up your strength, maintain your strength. And maintain your flexibility.
Yeah, so slow and steady.
Slow and steady, and keep that weight under control.
Yeah, absolutely. I know you focus on the specific areas. Do you think that those areas are getting worse in terms of you're seeing more of these cases, or is it kind of like a steady state?
Is it more? I think there's more awareness, and that's what social media brings. So some things where perhaps people may have put off and thought, oh, well, it's just part of menopause, I've got to put up with it. They're more likely to present. I happen to see a lot of women, mainly because I think when they have their multiple joint pains because of menopause, they're not always feeling they're getting a sympathetic ear. Sometimes, I'm not judging all my male colleagues, but a lot of them come to me because they don't feel that they've been heard. And so I see a lot of them. Not these things that don't actually require surgical treatment, but they just need some listening ear and a multidisciplinary approach. Whether that's to look at their diet, but certainly working very closely with physiotherapists. And I think that the pelvic floor is so key to a lot of problems. And as orthopedic surgeons, we're not trained to ask the relevant questions. Asking someone whether they have incontinence with sneezing or coughing. So it's nothing to do with orthopedics. So you don't want to go there. Is intercourse painful? Do you have any problems with your bowels? These are not questions that are going to be regularly asked. And a patient, even though they have those problems, have you got prolapse, etc., they're not going to volunteer because they also think that's nothing to do with my joints. But unless we start asking the questions, we won't be able to give the appropriate treatment to these patients.
How do you think that's related then? Because you're talking about lots of different things there, bowel issues during intercourse.
Yes, that's to do with the pelvic floor. That's a signifies pelvic floor weakness, and therefore you then have to do directed treatment there. But unless you ask the questions, you don't know. And if the pelvic floor is weak, the other muscles are compensating, and then they become inflamed.
Right. Yeah. And could that lead to hip issues?
Yes.
Right. And is that where hip replacements come in?
No, because this is to do with the tendons and the inflammation. This doesn't cause joint disease. So that's what I'm saying. A lot of these things can be addressed. And there's a significant proportion of women who are out there suffering needlessly. They don't require surgical treatment. They just need adequate physiotherapy. But if you don't direct it to the right place, they'll remain symptomatic.
I never actually thought about that. I know a lot of women go through issues with their pelvic floor. I also find, and I'm guilty of this, it's so hard not hard, but it's almost like the last thing you do or want to think about doing pelvic floor exercise.
Yes.
Because it's not a pain.
Yes.
There's no actual physical pain. It's not like my shoulder's really hurting and I'm doing these exercises to strengthen my shoulder, I can't feel my pelvic pain.
But you might have some of those symptoms I talk about.
Yeah.
So, you cough and sneeze and, and you just think, oh, well, that's part of aging. And then you just leave it. You see what I'm saying? But we need to be a bit more focused.
So I guess the key thing is when you do go and see someone, if they're not asking you the questions, you volunteer and tell them.
But I'm hoping this podcast will do is just help her to raise awareness, both within the medical professionals, but also in the patient population.
Yeah. It's looking at everything holistically and asking other questions apart from just about your shoulder pain or your knee pain. It's other stuff that might be going on that can be contributing to those things. And there's not always a case of, right, let's just scan your shoulder or something and see what's going on until you've done the work to address.
Yes. I mean, to be honest with you, insurance companies are now actually cutting back on what investigations they want us to perform. And an appropriate period of physiotherapy is always recommended. And so after that, if you remain symptomatic, then obviously you should definitely be investigated to see what else is going on. And then that can help direct your treatment as well, because it's helpful for the physiotherapist. But a lot of these conditions that I actually see don't require surgical intervention.
Which is intriguing, actually, because people assume that they just need surgery or there's something really serious going on, when just sorting things out through, like you say, physiotherapy can make the world of difference.
Physiotherapy, change of behaviors, to behavioral modification, looking at the way you do things. I mean, sometimes we need to do an injection, for instance, a local anesthetic and steroid, to get on top of the information so you can do the physio. But the baseline, the underlying treatment is physio.
Okay, that's great. Thank you, Samantha. Thank you so much for your insights. It's been fantastic to have you on.
Thank you very much. It's been a pleasure to be here.